Shaymaa Abdel Maaboud MD Cardiology in Shams University, Assistant Lecturer in HI Giza, Cardiologist, Chief Al Jazeera Medical Center, Manama, Bahrain. Today I'll discuss with you the fasting Ramadan with diabetic and cardiovascular patients. Fasting during Ramadan is one of the 5 pillars of Islam and commemorates a time when the Holy Quran was
دكتورة شيماء بعد إذنك في صوت لو حضرتك سمعنا.
أستاذ مسؤول الكمبيوتر، ها في مشكلة في
اونلاين ولا ريكوردد؟
Shaymaa Abdel Maaboud MD Cardiology in Shams University, Assistant Lecturer in HI Giza, Cardiologist, Chief Al Jazeera Medical Center, Manama, Bahrain. Today I'll discuss with you the fasting Ramadan with diabetic and cardiovascular patients. Fasting during Ramadan is one of the 5 pillars of Islam and commemorates a time when the Holy Quran was revealed to Prophet Muhammad, peace upon him. Ramadan lasts for 1 month per the lunar calendar year and is a fasting of any food or drink from the dawn to sunset. While recommendations on safe fasting exist for patients with some chronic conditions such as diabetes mellitus, guidance for the patient with cardiovascular disease is lacking. The need of practical guidance on diabetes management during Ramadan fasting. This is need to who fast during Ramadan had generally been based on expert opinion rather than the medical evidence guidance from scientific data. However, IDF DAR Diabetes and Ramadan Practical Guidelines 2016 provided a practical tool to help healthcare providers support their approach to safely guide people with diabetes who wish to fast the holy months of Ramadan. Epidemiology of diabetes in Muslim population in 2019 number of people living with diabetes globally was estimated to be 463 million, with a rise of 51% to 700 million expected by the 2045. Number of people with diabetes in the Middle East and North Africa is a region of high proportion to inhabitants, and similar increase is expected in Southeast Asia, another area where Islam predominates. Fasting during Ramadan has a number of physiological effects on both hemostatic and endocrinology process. In people with diabetes, these changes and the type of medication can be taken to treat diabetes can be associated with development of complications such as hypoglycemia and hyperglycemia. Ramadan fasting not only alters the timing meals, but it may also disturb sleeping patterns and circadian rhythms, all of which can affect individuals' metabolic state. Understanding changes can help the management of fasting. Physiology of fasting in diabetes, gluconeogenesis and ketonegenesis, increased glucose uptake, and the liver glycogen stores depleted, excessive breakdown to glucose to the muscles, and also pancreas insulin secretion decreased or absent. Fasting during Ramadan for people with diabetes carry considerable challenges. Individuals with diabetes should schedule a pre-Ramadan assessment with healthcare providers in order to discuss their decision to fast. This will enable the physician to assess Risk provide advice and produce an individualized treatment plan with correct guidance. Many people with diabetes can fast. This is important slide. This is to how to risk stratify patient fasting in patient with cardiovascular condition according to IDF risk category. We have three categories. Number one is moderate to low risk, which may be fast or listen to the medical advice of the doctor and help them to fast, like stable hypertension, stable angina, stable non-severe heart failure, ejection fraction more than 45 or 35, and HFpEF, implantable loop recorder, permanent pacemaker, mild to moderate valvular disease, supraventricular atrial fibrillation, sustained VT, mild to moderate pulmonary hypertension. But the high-risk group shouldn't be fast, like poorly controlled hypertension as defined by your specialist, recent acute coronary syndrome infarction less than 6 weeks, HCM with obstruction, severe valvular disease, severe heart failure without advanced features, poorly controlled arrhythmias as defined by your specialist, high risk of fatal arrhythmias, inherited arrhythmogenic syndromes or arrhythmogenic cardiomyopathy, implantable cardioverter defibrillator plus or minus CRT therapy. Very high risk people must not fast, advanced heart failure, severe pulmonary hypertension. This is also risk stratification to diabetic patient. Low risk patient can we do for them pre-Ramadan clinic assessment and counseling. Like low risk patient can fast with advice like type 2 diabetes on diet, will control type 2 diabetes on oral hypoglycemic agents. Intermediate risk, this category can be clinical assessed, including to annual review on feet, eyes, assess susceptibility to fast, including complication. Can be fasting with advice under supervision, like stable type 2 diabetes on diet or short-acting insulin or sulfonylurea, and moderate glycemic control, HbA1c 7.5 to 8.5% without major complications. The very high risk category is advised not to fast and optimize their glycemic control, lipid control, blood pressure control. These patients like type 1 diabetes, hyperosmolar hyperglycemic coma in last 3 months, macrovascular complications, comorbidities such as renal or liver disease. This is how to our goals in the care for the patient in Ramadan: control their symptom and prevent complication by assess key patient characteristic and risk stratification, consider specific factors which impact the choice of treatment and decision to fast, share decision making to create a management plan, agree on management plan, smart objectives, implement management plan, and oncoming monitoring and support, including review, agree management plan. Management to diabetic patient during Ramadan depend on changes in medications, frequent monitoring to the blood sugar, meal planning, exercise, how to recognize and manage potential risk, and how to break the fast if there is any complication. Recommendation for the patient with diabetes who fast during Ramadan. This is the category very high risk, which listen to the medical advice and please must not fast. One or more of these of the following: severe hypoglycemia within the 3 months prior to Ramadan, unexplained DKA within the 3 months prior to Ramadan, and hyperosmolar glycemic coma within the 3 months prior to Ramadan, history of recurrent hypoglycemia, history of hypoglycemic unawareness, poorly controlled type 1 diabetes, acute illness, pregnancy in pre-existing diabetes, chronic dialysis, CKD stage 3, 4 to 5, advanced macrovascular complication, old age, and ill health. This is the smart chart for the cardiovascular and the primary care physician, for the family medicine doctor, for internist, how to deal with the patient. Does the patient is intend to the fasting for Ramadan? No, continue current management. Yes, risk stratify the patient. This is the first step, as we discussed before in the past two slides, for diabetic and for cardiovascular diseases. We will categorize the patient to three categories: low or moderate risk, high risk, very high risk. Very high risk and high risk recommended should not, and the very high risk must not fast. Both of them, if the patient still choose to fast, we should explore the alternative for safety and give him risk communication and risk management. If the patient is in low moderate risk, we can recommend for him maybe fasting. So if the patient is taking cardiac medication, yes or no, go to risk communication. Yes, we should modify and optimize the compliance of the, or management for this medication. And for the risk communication, we inform the patient how risk status, document the patient risk, and the risk management as counsels the patient about dehydration, fluid overload or dehydration or electrolyte abnormality, and the comas may face, and how we can recommend how to deal in these situations. Suggest a pre and post Ramadan checklist for reviewing patients with cardiovascular conditions, establish patient background, and review recent investigation like EKG, echocardiogram. If he has the intracardiac device, we should check. Risk stratify the patient, and the communication management like refer patient to Ramadan, and diabetes CKD guidance and relevance, communicate risk and provide evidence. General Ramadan advice for him for healthy diet, fluid intake, smoking break, and smoking cessation chance, terminate fast if you're feeling unwell, IM injection and sublingual medications, do not break Ramadan fasting. And post-Ramadan review is very important to explore experience of Ramadan and how he can deal in the futures. Fasting-associated dehydration may lead to electrolyte abnormalities, which could be life-threatening in patients with unstable arrhythmias, inherited arrhythmia syndrome, long QT, Brugada, or on medications such as class 1C antiarrhythmic digoxin and renin-angiotensin aldosterone antagonist. Many cardiac patients can induce hypotension and potentially precipitating syncope, particularly in elderly patients with impaired vital reflexes. This may be exacerbated by dehydration or shortening the interval between the time and breakfast dose of medication if the medication dosing is altered by patient trying to facilitate his fasting. Hypertension, in the many trials, they found that they can significantly decrease systolic and diastolic blood pressure in individuals using diuretics, which was well tolerated without complication, and improve the BP control in patients with hypertension, irrespective renal function, and improve the arterial compliance in those without CKD in patients undertaking Ramadan fasting. CCCS اللي هي chronic coronary syndrome, the observational study led by and defined by European Society of Cardiology reported that Ramadan fasting was not associated with an increased cardiac mortality or morbidity within 29% of patients reporting improved cardiac symptoms. Similar findings were seen by this study on the CCS and the normal LV function. Acute coronary syndrome, also many trials and the ICAL of European Society also defined as a patient in many trials during and after Ramadan, month before and over 6 years period, they noted no significant differences in incidence of acute coronary syndrome in Ramadan when compared with the preceding or following month. The multicentric studies also reported that fasting within 3 months of percutaneous coronary intervention had a higher incidence of significant cardiac event than those who didn't undertake Ramadan fasting. heart failure. Also, many randomized trials provided that reduced ejection fraction, HFrEF, need to close monitoring, and this is no need for worsening of the heart failure symptoms during Ramadan. If they took fluid restriction and good medication, less likely to experience worsening heart failure symptom. And the retrospective also review for the more than 2,000 patients hospitalized with HFrEF over 10 years period found no increase in the number of heart failure hospitalization in Ramadan when compared with other months in the year. An expert panel examined safety of SGLT2 inhibitors for the patient with heart failure, and they should be initiated in a low dose and in the evening at least 1 month before Ramadan. Fluid intake should be increased during non-fasting hours. Hypoglycemia should be avoided by reviewing any concomitant medication for type 2 diabetes and with combination with SGLT2 inhibitors should be avoided in elderly and patients with CKD or those receiving loop diuretics. Arrhythmias. Disturbance of cellular metabolism and ion channel function can result in cardiac arrhythmias, and ESC 2020 Sport Cardiology advises the patient with long QT syndrome should carefully avoid dehydration. American Heart Association guidelines state that sleep cycle and eating disturbances common in Ramadan fasting could lead to increased incidence of AF. Multicentric studies also they reported that Ramadan fasting and receiving oral anticoagulation for AF received warfarin and the remaining received DOACs. More than 50% modified their anticoagulation regimen intake time, skipped doses, or drug being taken at the same time 2 times per day without prior consultation with their physician. Patients received 2 times per day DOACs were noted to be more likely to change their anticoagulation administration and more likely to be admitted to the hospital with a consequence of their changes, for example, bleeding or stroke. Intracardiac devices, there are no studies assessing patients with pacemaker undertaking Ramadan fasting. We deem them to low moderate risk provided they have no electrolyte abnormalities and their device clinic feels their device parameters are stable. Patients with cardiac resynchronization therapy or implantable cardioverter defibrillator would be deemed at least high risk, as they only indicated in patients with severe HFrEF and patients at significant risk of ventricular arrhythmias. We advise these patients with intracardiac devices to inform their device clinic in their next device check of their desire to fast in Ramadan. And a remote of in-person device checkup just before Ramadan would be ideal to ensure there are no issues that may prevent patient fasting. COVID-19 related cautions. If a patient is unwell with COVID-19, advice against fasting in a pandemic or post-pandemic phase. Routine reviews by specialist or general practitioner where patient could discuss the risk of Ramadan fasting may not take place. But healthcare providers should bear these points in mind with risk stratification their patients with cardiac disease and diabetes for the Ramadan fasting. Conclusion: the literature of Ramadan fasting in patients with cardiovascular diabetic disease is limited. Our review highlights that important role of HCPs, healthcare providers, play in risk assessment, providing advice, education, encouraging medication compliance and monitoring to enable patients where safe to do so to fulfill their religious obligation while minimizing the potential for harm. As patients with cardiovascular diseases often have non-cardiac comorbidities, our recommendation should be used in combination with those of Ramadan fasting in non-cardiac conditions such as CKD, diabetes, and epilepsy. There is a strong need for patient HCP and religious community leaders to engage with each other to discuss the contemporary medical issues. Further studies are needed to explore gaps in knowledge around fasting to help refine current recommendations. And thank you. Healthy Ramadan diet plan is an important step in this lecture, and also risk stratification for the patient, diabetic or cardiovascular diseases by our healthcare providers. Thank you all for giving me this chance to be with you in this day, and I'm happy for any question, and thank you again.